Good afternoon, and thank you for joining us at this webinar. On behalf of Dr. Robert Gropler, the Editor-in-Chief of Circulation Cardiovascular Imaging, and Dr. Kaz Negeshi, who will be co-moderating with me today, and the rest of the editorial team at Circulation Cardiovascular Imaging, we'd like to welcome you. We're very excited to present this session today with an international cast of presenters on the webinar entitled Advances in Artificial Intelligence Applied to Cardiac MRI, Highlights from Circulation Cardiovascular Imaging. We have selected these three publications from Circulation Cardiovascular Imaging that have been published in recent months in our journal to showcase, given the exciting findings they presented. My name is Shadi Ayub. I'm a professor of medicine at the Mayo Clinic in Phoenix and serve as section editor for digital media strategies for circulation cardiovascular imaging, along with Professor Kaz Negeshi, who is co-moderating today, and he is a professor of medicine and chair of cardiovascular research in southwestern Sydney and Sydney, Australia. So the three papers we're going to review in detail today all relate to artificial intelligence applications applied to MRI. The first paper relates to automation of strain to predict cardiovascular events. The second paper will present novel techniques to recreate an LGE-like image for analysis that might replace the need for late gadolinium enhancement. And then the third study will look at more disease prediction from cardiac MRI images applied to cardiac MRI. So really the full spectrum of applications of artificial intelligence to MRI. And without further ado, we'll launch into the first paper that we're going to review today. And I have the pleasure and honor to introduce Dr. Andrea Afani to present her work. She is a cardiologist in training in Romania, specializing in multimodality cardiovascular imaging. Her clinical research and work focus on inherited cardiac diseases with a particular interest in cardiomyopathies. She's completed her PhD dedicated to evaluating cardiomyopathy and is driven by an interest to bridge advanced imaging and genetics to improve patient care. She'll be presenting her work, which she carried out in France with the artificial intelligence team there. Over to you, Dr. Afani.
Thank you so much for the kind invitation. I'm happy to start this wonderful webinar. So today I'm going to present you our study from France, which is entitled Prediction of Cardiovascular Events using fully automated global longitudinal and circumferential strain in patients undergoing stress CMR. As you know, stress perfusion is a non-invasive method for the detection of myocardial ischemia in patients with suspected or known coronary artery disease. While visual assessment of stress-induced perfusion defects is the standard for identifying ischemia, recent studies showed that strain imaging at rest and at stress can provide prognostic value. Since manual contouring for strain analysis is very time-consuming and also has a great variability, AI fully automated assessment of global longitudinal strain and global circumferential strain could be beneficial. This way, our study aimed to determine whether or not combining AI-based fully automated GLS and GCS could provide incremental prognostic value to predict MACE above traditional prognosticators in patients referred for stress CMR. This was a retrospective single-center study where we included all patients referred for stress CMR between 2016 to 2018. After applying all the inclusion criteria, and after removing patients that were lost to follow-up or patients where the AI algorithm couldn't perform the measurements, our final cohort consisted in 2,778 patients. We used as the primary outcome a composite outcome of major adverse cardiovascular events, including myocardial infarction, cardiovascular death, and hospitalization for heart failure. CMR protocol and analysis. We used our routine protocol, which in this study has a limitation that I want to mention from the beginning. As you can see, I don't know if you can see my mouse. The cine images for long axis, for chamber 3 chamber 2 chamber, were acquired just before the administration of the stress agent. So this way we could only get GLS at rest. The cine short axis stack was acquired just after the stress perfusion. So this way we got the GCS only at stress. Statistical analysis. We reported continuous variables as median and interquartile range due to their abnormal distribution. Categorical variables were reported as frequencies and percentages. For group comparison, we use Wilcoxon rank sum test or chi-square or Fisher's exact test. Then we perform survival analysis with Kaplan-Meier curves. And based on proportional hazard assumption, we either use log-rank test or a weighted log-rank test, in this case, Peto test. Then we perform Cox regression to determine the predictors for MACE. We used a C-tree to identify the best cutoff of strain parameters to predict MACE. And we used nested Cox models to determine the incremental prognostic value of rest GLS and stress GCS. This way, we had 4 models. The first model was based only on traditional risk factors such as age, sex, obesity, diabetes, hypertension, dyslipidemia, smoking, and history of coronary artery disease, with the addition of, I would say, classical CMR parameters that are predicting MACE, such as left ventricle ejection fraction, number of ischemic segments, and number of LG segments. Second model has all the variables from the first model, plus rest GLS. Third model, again, variables from the first model with the addition of stress GCS. And the fourth model is the one having both rest GLS and stress GCS. For each model, we tested the performance by determining the C index, the NRI, IDI, the chi-square, and the likelihood ratio test. As I previously said, the first step was to determine the best cutoff for the rest GLS and stress GCS to predict MACE. This is the C-tree, and as you can see in the first node, the best cutoff to predict MACE in case of GCS is around -10%. And if you look on these 2 other nodes, for GLS this time, you can see that the cutoff is similar, also -10%. So it's very easy to remember. It's -10% for both strain measurements. The baseline clinical and CMR characteristics stratified by the cutoff for rest GLS. First, I want to mention, to remind you that higher values, meaning less negative values, are those that are abnormal. So the last column. So patients with abnormal GLS are older patients, are more frequently males. And if we look at the CMR findings, they have bigger left ventricle volumes, smaller, lower LV ejection fraction. They have more inducible ischemia, and more abnormal GCS. And if we look at the outcomes, you can see that they experience more frequently all the outcomes. If we look on the same variables but stratified by stress GCS this time, you can see that the findings are pretty similar, with the exception of more frequently presence of LGE in the cohort with the abnormal GCS. The primary outcome, after a median follow-up of 5.2 years, almost 18% of patients experienced MACE, and 6% of them experienced all-cause death. Who are these patients that died? Well, they are older patients with bigger LV systolic volume, with lower ejection fraction, with more ischemia, more LGE, and very important, more abnormal GLS and GCS values. If we look at the prognostic value of REST GLS and stress GCS, I'll point out directly the multivariable analysis, where we can see as independent predictors some traditional cardiovascular risk factors, such as advanced age and dyslipidemia. And if we look at the CMR parameters, we can see as predictors ischemia extent, LG extent, and GLS and GCS. If we look at the Kaplan-Meier survival curves for MACE, the one on the left is for the AI measured REST GLS, and the one on the right is for AI measured stress GCS. We can clearly see with red that patients with abnormal REST GLS or stress GCS are doing worse, with the highest hazard ratio for the GCS, where these patients have a 4-fold increased risk for MACE. If we look at the prognostic value of both REST GLS and stress GCS, we can see with black those that have abnormal GLS and GCS. They have a very high hazard ratio of 5.6. For the incremental prognostic value of REST GLS and stress GCS, we used 5 parameters, and as you can see, model 4, the one that have both GLS and GCS, has the best performance by looking at each of the 5 parameters. In conclusion, in our cohort, AI-based fully automated REST GLS and stress GCS were feasible and accurate in 96 of the patients. Both REST GLS and stress GCS were strong independent predictors of MACE. The best REST GLS and stress GCS cutoff to predict MACE were both minus 10%. Combining both measurements improved discrimination and reclassification beyond traditional prognosticators and stress CMR findings. To our knowledge, this was the first study to investigate the incremental prognostic value of combining both measurements for the strain in patients referred for stress CMR. Thank you for your attention.
Thank you, Dr. Erfana. This is Kaz Negis from Sydney. That was an excellent presentation and congratulations for your work. So for the online audience, please use the Q&A function underneath the screen and to ask the questions. This is a great opportunity to directly ask the questions for all three papers today. So this is an excellent work, and you did beautifully in terms of methodologically and with the outcome measures. So I understand the limitations of the resting GLS and stress GCS. So I wonder if you could share your thought on if you have the stress, both resting GCS and GLS, and both stress GLS and GCS, would it improve the performance of your technology?
It might improve, yeah. My idea is that having GCS, even if it's at rest or at stress, it's more predictive because of the distribution of myocardial fibers. I assume that circumferential fibers that are in the middle of the myocardium, not at the endocardial border as there are the longitudinal ones. It means that when those are affected, the disease is more advanced. So my opinion is that even if it's at rest or at stress, GCS is the most important one to predict MACE. That's my feeling.
Especially, and that because it reflects the more advanced cardiovascular conditions. I agree
Yeah.
with you. So probably the audience would be interested in the AI part of your analysis as well. So could you share your the experience, how easy or how difficult to apply your AI algorithm or technology?
So we used an algorithm which is only for research. So it's not implemented in any software yet. And we only put there the images, the acquired sequences, and the software, not the software, but the algorithm takes like 20 seconds for each patient to give the output. So it's very fast, very accurate, as you saw. So my feeling is that in the future, we can implement this in each software and we can get the output almost instantly. So maybe it can help to better
That's
stratify the
exciting.
risk of our patients.
Yeah, it is. I think the Professor Shadi would have some questions for you as well.
I want to join Professor Nageshi to congratulate you on this really outstanding work. A lot of questions that come from our readers are kind of a follow-up to Professor Nageshi's last question on practical grounds. So it's not commercially available. This is a machine learning algorithm that was developed at the institution where you worked. And it produces numbers for GLS and circumferential strain. Does it also produce a target map so that you could see which segments the strain was reduced to help with regional assessment, one, and two, when it generates the contours, did you have to manually adjust them a lot, or was the experience that it was pretty accurate in general?
So for the first question, the algorithm presents the results for each segment. So you can clearly see which segment is affected, not only the global value. So it's very, very useful. And for the second question, what was it?
Does it take a lot of contouring? So does it produce endocardial contour, and did you have to adjust it a lot?
So in our case, we only included patients that had fully automated, so no manual contouring. 96% of patients had this automated strain. You can correct it, but we didn't include that. So a small proportion of patients based on image quality require manual correction, but I think numbers are great with 96% of them having good strain analysis.
certainly impressive because the experience generally with automated software is that it might need a bit of adjustment, particularly with kind of a bit of haziness around the blood pool and the myocardial kind of interface. So that's impressive, and your work clearly demonstrates the prognostic significance in a very graded manner. So congratulations.
Okay, so we move on, and this is my great pleasure to welcome Dr. Yue, Shojun Yue. I hope my pronunciation is not too far from the actual one. He's a third-year PhD candidate in biomedical engineering at the Innovation Research Department, Chinese PLA General Hospital in Beijing. He has been actively engaged in MRI research with a strong focus on clinical cardiovascular magnetic resonance, quantitative MR techniques, and artificial intelligence in medical imaging. Over the past 3 years, he has authored more than 10 peer-reviewed papers in leading international journals like Magnetic Resonance in Medicine, European Radiology, and JMRI, and he has presented over 20 abstracts at the international conferences. With the combination of the cardiovascular imaging expertise and research insight, he is committed to advancing the clinical translation of CMR and exploring deeper, high-impact application of AI for cardiovascular imaging. The title of the paper, with congratulations, is the Synthetic Contrast-Free LDE via Diffusion-Based Framework in Acute Myocardial Infarction. Without further ado, over to you, Dr. Yue.
Thanks for your introduction, Professor Case. Good afternoon, everyone. My name is Xiuzheng Yu. I'm very honored to be here and grateful for the invitation. It's a pleasure to have the opportunity to introduce our work on contrast-free LGE via diffusion-based framework in acute myocardial infarction for image quality and quantitative scar analysis. This research applies a diffusion model to cardiac MRI, specifically targeting contrast-free LGE imaging. For the clinical challenge, as we know, ischemic heart diseases remains a leading global causes of mortality. While LGE CMR is the global gold standard for scar visualization. It has critical limitations, as we know. Gadolinium-based contrast agents accumulate in renal failure patients. Half-life extends from 90 minutes to over 3 hours. Additionally, LGE excision alone takes approximately 5 minutes. This has motivated our to explore contrast-free LGE synthesis to ensure patient safety in renal impairment and reduce scan time will improve CMR workflow. Exciting contrast-free methods include VNE, which published by Zhang Qiang, and CNE published Qie Haikun. However, both have limitation in accurate MI. As we know, VNE relies on native T1 mapping, which is limited by edema and MVO in accurate setting. By contrast, T2-weighted image, particularly T2 stir, more directly reflects increased water content and provide clear edema declination in acute setting. CNE just only used the CNE MRI, lacking the ability to distinguish necrosis from MVO. Moreover, current study relies on GAN generator model. For us, diffusion model, state-of-the-art generative AI, offer high-quality generation without model collapse, which is a limitation for other model, presenting an innovative opportunity for this clinical problem. Our objectives are fourfold. The first one is developed a diffusion-based framework. We call it MS-DIF, with multi-sequence guidance integrating CNN, MRI, and T2 stir. Second, generates the synthetic native enhancement image, LGE-like image modality. The third, comprehensive evaluate image quality with the real LGE in clinical practice. And for the fourth, validation clinical utility for quantitative scar analysis in acute MI patients, which is very important for the radiologist doctors. Our hypothesis is SNE will achieve comparable or suitable image quality to conventional LGE with strong agreement in scar quantification. Regarding methodology, first the slice and phase matching were performed across 3 sequences, CNN, T2, and LGE. You can see the slice match slice. After cardiac localization and cropping, feature extraction was designed for T2 and CNN, include edema highlighting, high frequency displays, and motion abnormality and graceful abnormality clues. And our conditional inputs include aligned CNN frames and T2 image. Motion abnormal prompt map highlighting the bottom 25% motion regions. Grayscale abnormal maps for top 25% intensity regions, and high frequency signals indicating edema or MMO. The key innovation is our dynamic conditional routing gates, which adaptive weighted each input source during generating. The MS-DIF framework comprises 2 complete components. The first one, CNN LSTM achievement process 2 consecutive CNN slice, extracting myocardial motion information and spatial temporal relationships, integrating into UNet view cross attention. And the second one, the diffusion model handles the interactive denoising, a 2-stage process including forward diffusion, adding noises over T-types, and reverse diffusion will UNet learns to recover the original image from noises at each time step. Why we used this design? Because we hypothesize the diffusion model can find the real image detail from the noise. And we employed multi-center validation, including apical and basal slice plus imaging with serves artifacts. Internal and external test sets from different center validation model generalizability. Finally, a total of 331 acute MI patients. For testing, we have 185 patients. Internal testing, we have 46 patients, and external testing, we have 100 patients. And then we compare the image quality, and subjective evaluation shows SNE outperforms LGE. Letcon scores internal test SNE, we have made 4.25 versus LGE just 4. External test set SNE also have the same results. Both the differences were significant. And internal observed ICC value of 0.833 and the same results demonstrate excellent consistency among 5 experienced radiologists. Objective evaluation revealed that SNE achieves the super tissue contrast will avoid several artificial present in LGE. You can see some, this is real LGE and this is a synthetic LGE image. It can avoid some artificials caused by patient's move or the patient which cannot breathe hold. This is consistent with the higher SNE scores in subjective evaluation with superior tissue contrast and the absence of articulation. That's always the can in the example. And for the quantity score assessment, we calculate the score size and stress memory, both as sports visualization, the spatial location, size, and the transmissibility of infarct scars, with you can see from the A to C from the internal test and D to 5 from external testing. We can see the results. Quantitative score analysis reveals strong correlations. Score size correlation about R value is 0.839 internal, and for the external R value is 0.816. For the transmissibility, we also have the good results, but we also can see some minor bias of only 2 or 3%, confirming stream agreement from SNE and LGE for infarct detection. And for the MVO generation, which is difficult for the before method, SNE demonstrate moderate capability, about 67% in internal and 63% in external test setting. This indicates that MVO generation remains high challenging with the room for improvement. Expanding this axis and designing finer feature capture may help in the feature work. And for the detail of the model, the high-frequency detail enhancement and abnormal mapping visualization provide institute interpretative explicit guidance reveals the rationale of leveraging non-contrast sequence for LGE synthesis, enhancing model transparency. And you can see the sequence countries for the distinct thinning provides the thinning image provides global structure and style, and the T2 star highlights ITMA regions, and multi-sequence fusion strategy ensures accurate pathological feature capture. You can see the what we call the multi-sequence fusion strategy. And for the conclusion, the MS diffusion successfully generated high quality contrast-free LGE-like image. And we have some key font. First one is the SNE demonstrates significant super image quality compared with real LGE. The second one, excellent quantitative agreements in scar size and transmissibility with minimal bias. As we know, the scar size is very important for the acute MI patients. The third one is robust generalizability across the multi-center data sets. And the fourth, clear clinical utility for reduced injecting good linear injection administration, particularly benefiting renal impaired patients. In the future, we also want to expand to other cardiomyopathies and improving amyloid generation, developing lightweight versions, and enhancing input robustness. And this all my slides. Thanks for your attention. I'm happy to take questions, and if you have questions, we can discuss in the future. Yes, thank you.
Okay. Thank you very much, Dr. Yue. That was excellent presentation and a terrific work. Very exciting, the giant leap on this field. So I'd like to remind the audience, if you have any questions, please feel free to use the Q&A function. And then while we are waiting for that, I might ask if just to check with my understanding is correct, because this is very technically demanding work. So basically, you picked two sequences, Cine, MRI, and T2 sequence, and then combine them, they apply your AI algorithm, basically CNN, also the LSTM, long short-term memory ones, for three levels next to each other. Is that correct?
Yeah, that's correct. But we used the CNN-based LSTM just for mainly focused on thinning because it's
Right.
multi-slice and multi-hot phase. It provides some motion information for the model. And for the T2 star, we just used such as radiomics feature. We extract T2 star image. We extract some feature from T2 star, just one slice.
I see. Now I see better. Okay, thank you. And then so when you 5-scale the Likert analysis, actually the image quality generated by your SNE, the non-contrast LGE was visually better for the the assessors. That is it's excellent and intriguing. And then based on your algorithm, you did this sort of the fantastic performance. So what was the theory behind there are previous the algorithms, and your algorithm performed better compared with previous one, isn't it?
That's good question. That's why we use the diffusion model. The diffusion model is generate image from noise. But why we have better image quality, SNE better than LGE, because we found that diffusion model can avoid some artifacts such as which caused by patient motion, and which some patient who can't follow the introduction to breath hold. So some motion artifact, but diffusion model can avoid this artifact when it generates image. So you can find it has some better image quality than other models. Besides, compare other models, diffusion model also we also use the multi-sequence and other research such as GAN, which proposed by Professor Qi, they just use the one sequence is thinning, and for the Professor Qiang, they just use the T1 mapping and thinning. So that's different. I think why is better than other model.
Okay. I would also congratulate you on this really outstanding work. I think it'll be transformative for clinical practice if we could do away with gadolinium in the future. There is a question, and I've got a ton of questions myself that I wanted to pose to you as well, and I'm sure Professor Nageshi as well. I just want to pose this one that's come from one of our attendees, Dr. Mihaela Stanchu. What would be the challenges to apply this method to non-acute pathologies like hypertrophic cardiomyopathy? And I'd even expand that further to other things like our next speaker will be speaking about, which is amyloid. Can your work, which has been done in the MI space, be applied to other cardiac pathologies as well?
Oh, that's a good question. It's our team are keep going on this direction. We want to try to use this this model to other cardiomyopathies such as HCM, or you mentioned that amyloidosis. But we it's still under research, but we want to use the other sequence such as adding some T1 mapping to improve this this function. Yeah.
Excellent, thank you. And before we move to our next speaker, I just had one question. You showed really spectacular ICCs and the examples you showed with the derived image and the actual LG image looked like they had close correlation. Are there any situations where your algorithm may not work as well in terms of be discordant with what real LGE would show?
Yeah, that's true. We also offer some case in our supplementary material because some if this patient is the image quality is not very good and the generation is not good, and for the especially for MVO, this model also cannot generate excellent retinal. So we still want to improve this function.
Excellent. Thank you very much, and congratulations again. In the interest of time, we might move on to our next presenter, and I have the pleasure and honor to introduce Dr. Lucas Weberling, and I apologize if I've given the American pronunciation of your name, who studied at the University of Heidelberg and completed residency in the Department of Cardiology, Angiology, and Pneumonology at Heidelberg University Hospital. He currently works as a cardiologist and clinician scientist specializing in cardiovascular imaging, particularly MRI and cardiac CT. His research focuses on innovative advances such as artificial intelligence, novel imaging sequences, and emerging biomarkers, with the aim of making cardiac MRI more accessible and more accurate. And it's with this background that he'll be presenting his recently published work in circulation cardiovascular imaging entitled Machine Learning to Automatically Differentiate Hypertrophic Cardiomyopathy, Cardiac Light Chain, and Cardiac Transthyretin Amyloidosis, a multi-center CMR study.
Yeah, so thank you for the very kind introduction. It's a pleasure to talk today and to be invited to this very interesting webinar so far. After the prognosis part and the technical part and the preclinic, It's a pleasure to move on to diagnostics, to the clinical life. So yeah, I want to start by showing you my disclosures first of all, by asking very simple questions. They're not cardiac at all. Does anybody know what kind of plant that is? Well, I won't ask for the. I won't wait for the answer, but what we all do is we have these agents in our pocket that can answer simple questions for us. And that one became particularly relevant for me because I have this plant for 5 years now, and my little toddler was eating fallen leaves. So I was worried, is it poisonous or not? So I asked my chat agent on my cell phone, is that poisonous? So this is not made up, it's real, so it's in German, but I translated here on left. It just said, well, this is potos, and it's poisonous for little children. So I was kind of worried. And I think that's the idea. We all have these AI agents in our pockets now. And I think as clinical images, we sort of strive to have that for our clinical life as well. And we are reluctant because we don't know how reliant is all these AI, and we talk about a lot of hallucinations on all that. So this is the basic thought for our research, where we looked at hypertrophic cardiomyopathy, cardiac light chain, and cardiac transthyretin amyloidosis, and use machine learning to differentiate the three. So a little introduction into cardiac amyloidosis. For those of you who are not familiar with it, it's potentially life-threatening, but it's treatable. And clinically speaking, most relevant are the two subtypes, light chain and transthyretin. And current challenges are that it is still underdiagnosed. It takes a large diagnostic delay, and it's often misdiagnosed. There are two studies from France showing that actually 9% of hypertrophic cardiomyopathy patients are actually amyloidosis patients, and that leads to a large diagnostic delay, which is critical because most patients diagnosed already have a poor quality of life, and most therapies available today only slow disease progression. So that's relevant. So, but when we talk about AI, I have to mention my first example because it's not potos, like the AI said. This is a Swedish ivy, and it's not poisonous at all. So the AI was wrong, and well, this was just a plant, and I was worried for nothing. But when we talk about AI, it's very critical for our life and for our patients. So these were the aims we went when we set ourselves when we went into the study. We looked at healthy volunteers and the three hypertrophic phenotypes of the heart. We wanted to use a high quality of data, so really, really good data. But of course, little data as possible and a little effort as possible, because time and resources, all money and all that, and it's scarce everywhere. And most relevantly, we want to understand how our model makes decisions to really see why is it taking this path, why is it making this diagnosis, to really get some new insights for our clinical routine. And these are our methods. We conducted a retrospective multi-vendor, multi-center CMR study. So no limitations to vendors or field strength and centers. And we collected data from all over Germany, from over 50 referring CMR centers. So mostly tertiary centers that did the CMR. But importantly, all those entities were diagnosed at our center. So high quality and comparability of diagnosis. But they brought their CMR data to us. We had 400 participants in total, and we used standard data. So we used the segmentations you all use in clinical practice, but with the difference that it was mostly automated by an AI algorithm. But importantly, we did not include the images into the AI models, but we included the segmentation results. So the results from there, for example, strain rate, GLS, and all that, and added some standard clinical information. The aim was to add only stuff a general practitioner would have. So nothing fancy, no light chains or anything like that. Basic standard clinical information, put it into the machine learning model to predict our diagnosis. So we chose 3 data sets. The one involved everything we had, was still pretty basic. So age, sex, weight, height, and 2 biomarkers. Kidney function, that's all for lab function. Some simple yes/no symptoms, physical examination, medical history, and ECG questions. So no dedicated ECG AI analysis, just yes, no, AFib or yes or no, and like 4 questions like that. And of course, the CMR data. The second data set, we reduced deleted every clinical information. So just anything, when you just do the MRI, what you would have, which is age, sex, weight, and height for your contrast application. And in the third data set, we even went further than that and excluded everything that had to do anything with contrast agents. So no LGE sequences. And we did a screening sequence where our machine learning model first ruled out healthy from all the patients, then differentiated HCM from amyloidosis, and then differentiated amyloidosis subtypes. So these are the patient characteristics. Just a little overview. As you can see, around 100 patients per group. And well, the healthy volunteers were equally distributed amongst genders, while the patient groups were a little male dominated. And the biomarkers, as you can imagine, are a little elevated in the patients and more prominently in amyloidosis, as you all know. And the kidney function was normal or slightly decreased. So this is an overview, and as I said before, just standard and very basic patient non-imaging biomarkers went into the analysis. We just had 22 yes/no questions. This is a selection, and I want to use that just to give you a look at the New York Heart Association class. We had patients of all disease stages, and for example, everybody talks about carpal tunnel syndrome and amyloidosis, but if you look at the numbers, 23 to 45%. It's a good red flag, but it still doesn't make the diagnosis. So it's just a little piece of a puzzle there. And this table gets even more confusing if I come to the imaging biomarkers. But let's just go through the basics here. What you see on the right side are the group differences between every one of these selected imaging biomarkers. And we have had 185 imaging biomarkers, which we just got from our basic segmentation. So just strain rate and all that. So really nothing more than you would do in your clinical routine. And as you can see here, there are a lot of differences between each individual value. For example, look at the left ventricular GLS. It is 19 for the healthy, 14 for HCM, 12 for AL, 10 for ATTR. Okay, well, there is a difference, sure. But it doesn't really help you in your clinical routine because there's a large overlap. But since every single of these parameters, well, the majority, is different between those groups, these are all little pieces in a puzzle. And as we know, who is very good at puzzle solving, it's the machine learning models. So this is where we put it into machine learning. And this is the very first step. And I would say it's extremely simple, but can we identify these sick patients from the healthy volunteers? Of course, it's easy even for a beginner in cardiac imaging, but still reassuring to know. As you see on the left side, you see if everything is included, all data we have, and you see the area under the curve, and it's a perfect score, 1.0. And in the middle, you see just imaging data, still near perfect score, and for the needle-free data, still a perfect score. So now it gets interesting. Can we differentiate hypertrophy? So can we differentiate HCM from amyloidosis? As I said before, currently 8 to 9% misdiagnosis in clinical routine. And here the AI model performs extremely well for a nearly perfect score for if we put everything in there. And just for imaging, it's still an area on the curve of 0.98. And even, well, still, we all love our LGE sequences, to be honest. And I don't want to get rid of them because I love them. But still, with a needle-free CMR, still an area on the curve of 0.95. And then the last step, this is extremely interesting because this is something CMR, as you well know, is not really capable, or has been thought not to be capable of doing, is to differentiate subtypes of amyloidosis. And here, the performance is still extremely good. well, a little less, of course, but if you put in every data we have and just basic characteristics there, which means all data, is area under curve 0.992 on the left side, and if just for the imaging data, still 0.88, and for the needle-free CMR, still 0.86. So still not something, of course, you would just base the whole diagnosis on, but which can maybe point to the right direction there. So, but as I said before, we don't want to just trust the AI, we want to understand the results. And this is where we included a SHAP analysis. And what you see here is for every step, here on the left, the healthy versus patients, for the HCM versus amyloidosis, for ATTR versus AIL, and for every sequence, so just all data sets or just imaging or needle-free, the SHAP analysis. So the most relevant parameters that were that drove the decision of the machine learning model. And what we did here, and you can find this figure in the paper, is just the most relevant. We picked the most relevant ones and looked at the distribution between the two groups and just put it in a standard statistical model. So no machine learning, nothing. So what you can see here is just 6 on the 2 first columns, 2 first rows. You see 6 parameters and you see a cutoff. And if you just look at these cutoffs and combine them, you still already get an area under the curve of 0.89 to differentiate the two. So these are the most relevant parameters for the distinction of HCM and amyloidosis. And as you see here, look at the parameters, a lot of right atrial or right ventricular parameters are in here. And if you think about it, it makes a lot of sense because HCM is a left ventricular disease and amyloidosis is a systemic disease, which is can be found in the whole heart, atria as well. So this was quite interesting, and we did the same for AL versus ATTR, and the distribution and the same pattern. If you could just combine these 6 very relevant parameters and combine them with the cutoff we give here, you already get an area on the curve of 0.87, which is quite impressive. And we showed below that was the same for the first here, frequency and specifically of abnormalities you currently see, for example, diffuse LGE and all that, so you can sort of refine your diagnosis even more than that. And if you look at the parameters here, strain seems to play a large role in distinction, and of course age, as you can think. So let's look at our aims. We wanted to distinguish these entities using high quality of data. I think we achieved that. We looked through every CMR data set ourselves. But of course, if we want to go further, we need an larger scale to go on from here. And we wanted to use as little data as possible. I think we did that. It works without clinical data and even without contrast agents, so as little effort and maybe costs as possible. I hope you were able to see how our model makes decisions. And I think we got some new insights for clinical routine. For myself, we'll look more at the right atrium and a right ventricle from now on. And yes, so I want to conclude my talk and thank you all for your attention. Of course, the large team that was involved in the conduction of this study. I'm looking forward to the questions.
Thanks very much, Dr. Webering. That was an excellent work. So let me begin with the quick question about I really liked I think it's really smart to use the 3 steps approach. First compare with healthy versus diseased, then comparison in the HCM versus the amyloid and so on. So when you apply everything together and differentiate 4 distinct groups, would it perform less or similar?
Yeah, really interesting questions. And I think and they perform quite similar there. It's just easier to pour that way because very first step, as I said, is nearly perfect. So if you have an area under curve of 1.0, you already get the 3. And with the HCM, it was 0.98 or 97. So it's quite similar, actually. But of course, where it gets interesting is if you include more entities, and that's of course the next step. And overlapping entities, I would argue there are a lot of overlapping in entities as well. So yeah, that's it. It's where it gets interesting. But I'm looking forward to the steps ahead.
Wonderful. Shadi, would you like have questions
I might
before we
just
wrap up? Yeah.
offer one question, and really outstanding work. Congratulations. And it's super
Thank you.
exciting for work that's subtypes cardiac amyloid from a non-invasive approach. I just want to clarify for our audience. You commented this is not imaging based, so it's very different to say the ECHO paper that was published last year by Dr. Pelliker's group with 4-chamber ECHO-VUE predicting presence of amyloidosis. This is tabular data, so numerical data from MRI sequences that are fed into the model, and based on that numeric data, it will sub-differentiate the different pathologies.
Yes. So yeah, and I think that's a very different and very important distinction. Because I could go on for an hour to talk about so the problems or the bias you have if you include images, especially with CMR. As you probably know, in Germany we have this very strict data laws, and I think a very striking example is in Germany. It is not considered, you can't really anonymize CMR data. So it's because they always say, well, there's something in there where you can always track back your patient. And I think if our data regulations are that strict and say that, I think that's true. Because sometimes, and even when I went through data, it's always something in there which tracks back to the disease. Might it be, well, it comes from the amyloidosis center, or sometimes in our center, we used, for example, 40 images per heart cycle instead of 35 when we thought amyloidosis, or if you think HCM, you make a multi-slice 3-chamber because you want to look for the obstruction. So there's always something in there you don't have really know that leads to the diagnosis that has nothing to do with the images, but just because of the metadata. So that was really something that was the reason why we just included numbers and not the images there. Well, of course, the images have a huge potential, but for this step, I think it is nice that it works with the numbers as well.
Wonderful. So as we go beyond our 1 hour slot, so I think it's time to make a bit of the final statement. So, ladies and gentlemen, as we draw this insightful webinar to a close, I want to extend my deepest gratitude to our distinguished authors and to all of you for joining us today. We have just explored 3 truly groundbreaking papers that collectively signal a new dawn for the cardiac MR imaging. Today's presentation have brilliantly illustrated how AI and machine learning are no longer just theoretical concepts, but practical tools enhancing our ability in cardiovascular imaging. First, we saw that Dr. Afana and colleagues have truly automated AI-driven strain analysis can unlock the prognostic power of stress CMR. By combining REST GLS and Stress GCS, their model successfully demonstrated incremental value in predicting MACE over traditional risk factors. As the accompanying editorial by Dr. Zhu highlighted, this automation minimizes observer variability and reduces processing time, overcoming the major barriers to the routine clinical adoption of strain analysis, especially in cardiac MRI. In the second paper, Dr. Yu and research team presented the highly innovative MSD framework, which leveraged the diffusion-based generative model to synthesize contrast-free LGE-like images for the patient with acute MI. By using routinely acquired Cine and T2 sequences, this framework allows for the accurate quantification of myocardial scar size and transmularity without use of gadolinium-based contrast agent. This is a massive leap in the forwarding for the a massive leap forward for the patient safety, particularly those who has the contrast allergy or renal impairment, and also for improving clinical workflow efficiency. Finally, the Dr. Wavering team just presented, and also they tackled a diagnostic conundrum, differentiating the hypertrophic cardiomyopathy from the cardiac amyloid, and further distinguishing between AL and ATTR subtypes. Their three-stage machine learning cascade proved that the rich, high-dimensional data already embedded within standard and even needle-free CMR exams can be harvested to achieve near-perfect diagnostic accuracy. This means that patients could potentially be diagnosed earlier and detected towards the specific life-altering therapies much faster without relying solely on the highly specialized centers. The overarching theme today is clear. AI is unleashing the full potential of the CMR. It is making scans faster, safer by reducing the need for the contrast agent, and vastly more informative by extracting sub-visual biomarkers. While the journey from promising algorithm to robust real-world clinical tools will require further prospective validation and integration, the research shared today provides a thrilling glimpse into the future of the cardiovascular imaging. Thank you all again to our incredible speakers for sharing their pioneering work, and our audience for your engaging questions. We look forward to seeing how these innovations will soon translate into everyday clinical practice. By the time, and also have a wonderful rest of the day. Thanks very much for joining us.